Hello, everyone. Thank you for joining us this evening. My name is Stavroula Savelidis, and I'm the Executive Director of the Nassau County Medical Society and the Nassau Academy of Medicine. A few housekeeping points. We will be leaving everyone on mute during the presentation. At the end, you will have the opportunity to pose questions to our speakers via the Q&A box or the chat. In honor of Multiple Sclerosis Awareness Month, we are presenting tonight a highly informative webinar. Our speakers will be talking about symptoms, possible causes, treatments, goals of treatment, and much more. Our first speaker is Dr. James Stark. Dr. Stark is a board-certified neurologist at the International Multiple Sclerosis Management Practice. He received his bachelor's degree with distinction from Boston University and completed medical school at the Albert Einstein College of Medicine. Originally from New York, he continued at Einstein for his neurology residency training and was designated a chief resident of neurology during his final year. Dr. Stark then completed a 2-year neuroimmunology fellowship at the Tisch MS Research Center of New York with Dr. Sadiq. In addition to patient care, Dr. Stark serves as the Director of Clinical Trials at the International Multiple Sclerosis Management Practice and has presented clinical research on MS at numerous medical conferences. In 2019, Dr. Stark was elected a fellow member of the American Academy of Neurology, and he has received numerous top doctor awards by Castle Connolly and other physician recognition associations. Our second speaker is Dr. Armistead Williams III. Dr. Williams is the Associate Medical Director at the IMSMP. He received his BA with majors in biology and studio art at the University of Virginia. He received his MD and completed his medical internship at the University of Virginia Medical Center. He trained in neurology at the Neurological Institute of New York at Columbia University Medical Center. During his residency, he was awarded the 2005 Daniel Sciarra Patient Care Award for Outstanding Patient Care and Humanism. He joined the IMSMP in 2007 after a 2-year neuroimmunology fellowship with Dr. Saad Sadiq. Dr. Williams has been included in the following publications: New York Super Doctors, Rising Star Doctors in New York for 2014-2013, and selected for inclusion as a super doctor in New York for 2020, 2019, 2018, 2016, and 2015. Castle Connolly, top doctor in New York metro area in the field of neurology for 2021, 2020, 2019, 2018, 2017, and 2016. Without further ado, we welcome Dr. Stark and Dr. Williams.
Good evening. I'd like to thank the Nassau County Medical Society for inviting us to speak about multiple sclerosis during MS Awareness Month. And thank you, Stav, for that lovely introduction. As Stav said, we work at the International Multiple Sclerosis Management Practice, which joins our Basic Science Research Center, the Tisch MS Center of New York, and both are directed by Dr. Saad Sadiq. Dr. Sadiq left his position as chairman of neurology at the then Roosevelt Hospital, now Mount Sinai West, to found the center in 2007 because his passion is bench research, and he wanted a place where the clinic and the laboratory could seamlessly interact. Although I'm the director of our clinical trials, we hope to incorporate the lab in everything we do here. We decided to break up today's talk into 2 parts. I'll start with an overview about MS, and then Dr. Williams is going to dive into the treatment considerations. And although we've made progress in many aspects of the disease, the breakthroughs that we've made in the treatments of MS have revolutionized this field and led to this becoming a condition in which most newly diagnosed patients can expect to lead relatively normal, healthy lives. There are certain forms of MS that are more difficult to treat, but as Armistead will discuss, our goals of treatment are very different today than they were even 10 years ago. So let's take a step back just to really start from scratch. In MS, immune cells cause inflammation of the central nervous system by attacking the myelin coating of nerves. I'm not going to go through the complex neuroimmunology of this, but suffice to say that both T cells and B cells are involved. The involvement of B cells is a relatively new discovery, and now we have very effective treatments that target them specifically. So then there's migration of these immune cells through the blood-brain barrier, which results in inflammation and demyelination. The function of whatever region of the brain or spinal cord does is disrupted, causing various neurologic symptoms. It's important to note that it's not like a stroke with cell death, at least early on. It's that the lesion causes asynchronous firing of the action potentials. In relapsing remitting MS, the inflammation stops on its own after several weeks, and the nerves do remyelinate, leading to a gradual improvement of symptoms. However, the CNS can't repair itself 100%, and remyelinated lesions do not function quite as well as unaffected areas of the brain. And although active lesions can shrink a little, mostly from the acute edema resolving, chronic MS lesions never go away, pathologically or on MRI. This becomes very important when we talk about something called pseudo-relapses, which is the sort of day-to-day variability in MS symptoms that can be difficult to distinguish from a true active inflammatory exacerbation. And this is one of the most common issues that come up with other medical practitioners evaluating MS patients. So what's causing all this? Well, unfortunately, we don't know. There has been progress in the pathophysiology and cause of MS so that it feels like we're really circling around it, but we don't know what specifically is the cause of MS, of course. Briefly, research into the genetics of MS has been rather disappointing. MS is not a traditionally Mendelian inherited disorder. Very rarely do we see it run in families, but the chance of a first-degree relative having MS is about 2 to 4%, depending on the study. There are multiple genes that have been found to be upregulated, but only in some MS patients. The HLA-DRB1-1501 gene is the strongest association, but is also associated with a variety of other autoimmune conditions. The vitamin D receptor gene has also shown differential expression in multiple sclerosis patients, and has also been linked to autoimmunity. So I think there may be a genetic susceptibility to autoimmune disease in general, but not specifically to MS. Then there's a number of data streams indicating an infectious trigger for the development of MS. And a number of infections have been implicated over the years. I think the best evidence comes from Epstein-Barr virus. Although by a certain age, the vast majority of adults have been exposed to EBV, every single MS patient has been if you look hard enough, including children. EBV is also interesting in that it infects B cells and immortalizes them, taking them out of our body's natural regulatory framework. Finally, there are a few environmental factors that can affect the course of MS, including low vitamin D levels, hormones, and smoking. So when someone who is genetically predisposed to autoimmune disease and then exposed to EBV, potentially at a critical time later in adolescence or early adulthood, or perhaps a certain strain of the virus, can lead to the development of multiple sclerosis, the severity of which can be affected by certain environmental variables. So let's go through some other factors about multiple sclerosis. MS is the leading cause of non-traumatic disability in adults. 70% of initial presentations fall within 20 to 40 years old. It is uncommon in children, and one of the main differentials in kids is ADEM, or acute disseminated encephalomyelitis. Since I was in med school, the prevalence of MS has been listed as 400,000, which we knew was way too low. In 2019, 3 studies using national databases were published in one issue of the journal Neurology that put the estimate at more about 1 million cases in the US alone. There are about 10,000 new cases annually. Prevalence is rising, and we're not sure if that's due to increased awareness and improved imaging techniques, or if it's also rising on its own. In the relapsing form, more women have MS than men, and the sex difference may also be increasing. There are some racial differences as well. MS is more than 2 times as common in people with Northern European ancestry. Black people with MS may have a more aggressive disease course and an increased incidence of transverse myelitis, or inflammation of the spinal cord. And variants of MS, including optical spinal MS, are seen in certain Asian populations. We have known for a very long time that there's a geographic distribution for MS, in which your risk of developing MS is greater the farther you are away from the equator up to the age of 16. And that's irrespective of regions with different genetic variability. So here we have estimates for the US with Nassau County up here, right within the pink zone. But they don't actually show Long Island on this, which is unusual. One of the biggest factors leading to this distribution could be vitamin D levels. So in terms of the presentation of MS or the symptoms of MS, the symptoms of MS will vary widely depending on the site of the lesion and can include fatigue, cognitive impairments, blurred vision, double vision, slurred speech, weakness, numbness, bowel, bladder, and sexual dysfunction. So just as important as what the symptoms are is how the symptoms present. So there's different ways that someone can feel worse in MS, and that informs what subtype of MS they have, which in turn has very important therapeutic considerations. So the way the vast majority of MS patients present to a physician is with a relapse or attack or exacerbation. They all kind of mean the same thing. A relapse is caused by active inflammation of a part of the brain or spinal cord, causing new neurologic symptoms that last for several days to weeks, and then gradually improve on its own from weeks to months. Luckily, most newly diagnosed patients will have full recovery from a relapse, even without steroids. Over time, however, patients recover less well from repeated attacks. And because lesions or scars from this inflammation never really go away, relapses contribute to the overall disease burden, which may be the reason for progressive MS. A pseudo-relapse is important to discuss, especially for this audience. A pseudo-relapse is poorly named because that patient is really feeling symptoms. However, the symptoms are not from new immune system inflammation causing a new lesion. Rather, it's from those old lesions that never remyelinated 100%. And when there are extra stressors on the body, old MS symptoms can come out. These stressors can be a number of things like heat sensitivity or Uthoff's phenomenon, an infection even without a fever, another intercurrent medical condition, stress, lack of sleep. The list of things that can do this is actually very long, but there are a few ways to identify a pseudo-relapse from a relapse. These include the return or just worsening of old symptoms, especially if they are intermittent. If symptoms come and go, especially if they resolve completely and then come back, that's actually a very good sign that we're not dealing with a true attack. And this is why we have sort of a 24-hour rule before giving steroids for an attack. It's important to note that even in an actual acute attack, there's never really an emergent indication for IV steroids. You don't need it within the first few hours of an attack, like say a stroke with TPA. Also, multifocal symptoms, like when everything is worse, is another sign that we're not dealing with a single new lesion causing a symptom, but rather something systemically affecting the entire person and disease. So if a patient says, I'm stiff all over and my legs are weak and my vision is blurred, well, there's really no place in the brain that can cause all of those symptoms at once. So then we think of other systemic things that could be making everything worse. This is especially true of our female patients that are prone to urinary tract infections, for example. Sometimes it's difficult to distinguish a relapse from a pseudo-relapse, so then we'll do an MRI, because a pseudo-relapse should not show up as a new enhancing lesion on an MRI. By the same token, if I'm convinced an established MS patient is having an acute attack, I do not need an MRI to prove it. Finally, progression refers to a slow worsening of symptoms, and I mean slow over months to years, such that patients can never identify exactly when it happened. They'll say things like, well, last year I could walk 5 blocks without stopping, but this year I would need the support of a cane to do that. Progressive MS is associated with very little inflammation and few MRI changes, and we do not treat this type of worsening with steroids. We understand the pathology of progression the least well, and this is the most difficult type of MS to treat. All right, so in terms of the MS subtypes, here are some graphical representations of the different forms of MS that you'd see in a textbook. Now, I don't particularly like these categories. Broadly, I think of 2 types of MS. So here we have primary progressive MS, which behaves very differently to other forms of MS. And like something like neuromyelitis optica may wind up being a separate disease entity. Neuromyelitis optica was thought to be a subtype of MS that affected the spinal cord and vision only. But now it's a separate disease and we know more about it than we do MS, arguably. In PPMS, there's very gradual progression without attacks and without any recovery from symptoms. So then we have relapsing remitting MS with these attacks with recovery and over time periods of quiescence in between these attacks. But over many years, you recover less well from an attack. And then over time, up here with progressive relapsing MS, you have continued attacks, but there is progression in between attacks. And then after years of that, you get a more secondary progressive course where you very, very rarely have attacks, and it's more of just a slow, gradual worsening, which does really resemble primary progressive MS. So in that way, I see a continuum between relapsing remitting, relapsing progressive, and secondary progressive MS. I like this representation of MS a little better. Here we see a continuum of relapse remitting, relapsing progressive would be in here, and secondary progressive out here, all on one spectrum. Relapsing remitting starts with peripherally initiated inflammation, meaning immune cells from the body enter the central nervous system and cause inflammation, which over many, many years leads to degeneration and or CNS compartmentalized inflammatory injury, meaning that it's not coming from the rest of the body, but already compartmentalized in the CNS. And here we have our PPMS down here that's sort of doing its own thing. All right, in terms of the relapse and remitting secondary progressive spectrum, let's go into a little more details about that. So over 80% of patients present with relapse and remitting MS. Early on in MS, the annualized relapse rate is 0.7 attacks per year, which is about the average of every year and a few months the patients will have an attack. But there's much more going on behind the scenes, which is why we do so many MRIs in MS patients, even if they're asymptomatic. So silent plaques account for about 80% of MRI lesions in the brain. And if there is ongoing inflammatory activity, we want to know about it before it becomes clinically relevant. So we know a lot about what happens to untreated MS patients because for a very long time we didn't have treatments. Without treatment, 50% of relapse remitting patients will become secondary progressive in 10 years. And 60 to 85% will become secondary progressive in their lifetime. The median time to limitations of ambulation from diagnosis, so median time to any problems walking is 8 years. The median time to requiring a cane or crutch is 20 years. And the median time to wheelchair confinement is 30 years. So that means someone diagnosed at the age of 20 will be using a cane by the age of 40 and will be restricted to a wheelchair by the age of 50 on average. I'll leave Dr. Williams to drive home the point about early effective treatment being crucial to preventing permanent disability in MS. Relapses themselves often recover completely. It's the progressive course that results in the most disability accumulation. And if you think, as I do, that relapses now contribute to progressive course later, then stopping relapses early should prevent the development of secondary progressive MS. All right, so PPMS, primary progressive MS, is 10% of MS patients. The presentation is quite insidious, dragging of the foot or tripping more often, but in a progressive course over a long period, even decreased endurance. The mean age of onset is older, 40 years old, and can be 40 to 60 years old. Men are actually equally affected in PPMS, which is very interesting. Pathologically, the lesions are similar, but there are many fewer MRI lesions, and it's extremely rare to catch an active or enhancing lesion in PPMS. The rate of progression is similar to secondary progressive MS, and these patients are poorly responsive to treatment. All right, I'll wrap this up with how we diagnose MS. The history and physical is still the most important thing, and the MS subtype is entirely decided by the patient's history. Technically, to diagnose MS, you need to find evidence of 2 attacks separated in space and time, multiple sclerosis. But if someone's having their first attack, we can still use the MRI to identify old lesions to prevent an unnecessary delay in the diagnosis and the treatment. On the MRI, we look at gadolinium enhancement, which indicates an acute active lesion, as well as T2 or flare hyperintensities. So here's an MRI. On the left, we have the gadolinium sequence, and the gadolinium is injected intravenously. And if there's active inflammation at the time of the MRI, it leaks out. And so here's our enhancing lesion. On the right, we see the T2 or flare sequence. This is the flare sequence. And we see that these lesions are not enhancing, so they're the old lesions. And here we have a lesion that already looks a little bit funny because that's the one that's active or enhancing. And actually there's a second enhancing lesion down here that will correlate to this lesion here. On MRI, we also look at the shape or the morphology of the lesions, as well as the location to help differentiate MS from other disorders that also cause T2 hyperintensities. Finally, chronic, very old lesions may become T1 hypointense with a black hole appearance, which indicates a much more long-standing injury and cell death. Next, we do blood tests to rule out mimickers. This differs depending on the presentation, the patient, their location. For example, I like to have a negative Lyme test at baseline for all my newly diagnosed patients because we live in an endemic area and Lyme can cause T2 hyperintensities. These days, I think we do fewer LPs for diagnosis. I mostly do them if I think something else may be going on. And that's because the tests that we have for MS, the oligoclonal IgG bands, are only present in about 85% of patients. MS should have a normal CSF protein and a low or mildly elevated white blood cell count. Abnormal protein or WBC will make me consider another diagnosis. And finally, we really don't do evoked potentials for MS so much anymore. They'll probably be abnormal and they're just not specific for MS. So that used to be done quite a bit more. A couple of other interesting MRI things that I've come across is if someone does present with their first ever MS attack, especially optic neuritis or transverse myelitis, if they have even one lesion on their brain that is not correlated to the symptom, they have a 75% chance of developing MS in 10 years. And of patients, there was an interesting study where they looked at patients that were referred for asymptomatic MRI abnormalities. And of those patients, only 11% went on to develop MS. 45% had migraine, 22% had age-related changes or hypertension, and for 22%, there was no identifiable cause. Thank you very much.
I'm Armistead Williams, and in this 15 to 20 minute talk, I want to try to address specifically the question that you come up with of demystifying multiple sclerosis and how we make opportunities from a challenging presentation. So as housekeeping, this talk is intended for doctors of all types. So I'm thinking about what I would like to hear if a doctor were presenting about Crohn's disease. I don't need to know a lot of the technical details. I need to know broad strokes information about what's being done and how much has changed since I went to medical school. So this is a strategy talk. It's based on my experience, the basic science, as well as the evidence. And the experience of our multiple sclerosis center, which we've had a collective 50 years of experience treating MS in what used to be considered an aggressive fashion, but is now becoming relatively routine to be treating MS as well as possible. Still, this talk is not meant to be taken as the right approach. There are a variety of approaches that reasonable, good doctors will take to MS. This is just our approach to a complex, partially understood disease. I'll discuss rituximab, which is commonly used in multiple sclerosis, but is off-label and never went through a phase 3 trial. So it needs demystifying for several reasons, and some of this Dr. Stark captured, but it's heterogeneous from benign cases to severe, and the immune system may shift over time, as well as some people may have immunological variants. We don't get to detect that on the surface. Also, the outcomes that we're trying to prevent, such as disability, evolve over a long time, whereas the trials, placebo controls, are often just 2 years long. So we don't capture the ideal data to prove what's necessary for long-term outcomes. It also requires very long trials that without serial adjustments within those trials, which is not what we're actually doing when we're taking care of patients. And then another reason that it needs demystifying is that we're trying to treat an inflammatory process that's only partially captured by MRIs and relapses. And that makes it difficult to discern treatable inflammation from what may be called degeneration or non-MS processes, such as a medical illness that when someone doesn't look good, you have to be able to say, is this inflammatory MS? Is this something that's degenerative? Or is this a person who has a medical ailment or is on the wrong drug therapy? The other challenge is that there's a disconnect. Patients may come in and feel relatively well, and yet that is the time early on when therapies are most likely to be effective. The disease is most inflammatory and the treatments are most effective early on, whereas treatments are less effective when someone has sustained disability or has progressive disease. And then, important to note, the treatable MS evolves oftentimes into an untreatable progressive disability. And so we're left with, well, what do we do and how do we solve these problems? And how do we do the best we can for our patients? And in 2018, the American Academy of Neurology gave guidance that clinicians should counsel people with multiple sclerosis that disease-modifying therapies are prescribed to reduce relapses and new MRI lesion activity. So reduce relapses and reduce new MRI lesion activity. DMTs are not prescribed for symptom management in people with MS. That is, it gets translated loosely to don't take a treatment hoping to feel better, when that's actually what most people who come in and are symptomatic would like to feel better. This is a safe statement, and it allows doctors to have more liberty and not be responsible for outcomes, but it may be undershooting what we really can achieve. So a brief history of MS that sort of captures how much things are changing. In 1993, the first drug, beta interferon or beta seron, was released. It's actually so much in demand that it came out as a lottery. And then glatiramer acetate or Copaxone came out in 1996, and not long after that, Avonex came out. The first very powerful medicine, mitoxantrone, came out in 2000. And in 2004, I was in my penultimate year of residency and chose to go into MS. And I was told by good doctors, including a peripheral nerve neuroimmunologist, don't go into MS. They were very confident that MS treatments, like ALS treatments, were going to hit an impasse, and that these interferons and Copaxone were barely effective, and that nothing else was going to come. Even though it was that year or the year afterwards, we actually discussed natalizumab or Tysabri in a journal club. But I came upon a mentor, Saud Sadiq, in 2005, who I started training with him at that point, and he said we should strive for a crazy concept that's oversimplifying MS. We said, let's pretend that you can have agency, and that we should strive for no evidence of activity that we can see. So no MRI activity and no relapses. And at the time, this was, he was a pariah. This was something that was against the grain of what everyone said. We were really uncertain, or many doctors were uncertain, if this was an inflammatory disease or just an inflammatory epiphenomenon wrapped around a degenerative disease, because so much of neurology has been degenerative diseases and a history of frustration. So 2006 and 2008, Tysabri or natalizumab came out in 2006, 2008, rituximab came out. Some centers like ours started using rituximab from about 2006 on, because it had been used for treating rheumatoid arthritis and it showed some benefits. And we knew that there was a trial in MS. So that trial was a phase 2 trial, showed good benefits, but it was small. It was only a single year. Through this time, the conventional thinking remained that we should allow MRI inflammation in some relapses and only adjust treatment if people developed more disability, because that we could be sure what it meant. And the first publication describing freedom from disease activity as a concept was in 2019, and the idea of NEDA, or no evidence of disease activity, became more commonly discussed as a goal we should try for, but may not be able to attain in 2015. So there has been this disconnect. My point is a disconnect between when drugs were available to use and a decade later saying, well, maybe we should be using them with agency, so that the drugs educated us about what could be done, but we also had to evolve a strategy, or many people did. But it also captures the uncertainty kept us from being able to use things with as well as we could. So now we're in an age of therapeutic optimism, and there are over 20 therapies available for multiple sclerosis, and they range from highly effective to moderately effective to lower efficacy drugs. The highly effective drugs, the natalizumab or Tysabri, and then the B-cell drugs, Ocrevus, Kesimpta, and rituximab. People are rarely using mitoxantrone. If you're not an MS specialist, you shouldn't, and we haven't ourselves used it in quite some time. It's a lot of cardiac toxicities and risk of leukemia. Alemtuzumab or Lemtrada is also a highly effective therapy. And then they're moderately effective therapies. What you're seeing here are 3 different categories and then me too's, so that there's cladribine or madevinclad, several fumarates, with the archetype being Tecfidera, several of the S1P modulators, with the initial one being Gilenya. And then there are the lower efficacy drugs, glitiramer or Copaxone, and a biosimilar, beta interferons, and teriflunomide. So something to point out here is, while yes, we're optimistic, if you look at some of the hottest drugs like Kesimpta and Ocrevus, they are a repurposing of a drug that was first discussed in use in 2006. So there's still, we make big advances, and then it takes some time of just reiterating one drug and making me too's. But we are moving forward, and it's been really wonderful. So natalizumab, we're going to discuss 2 highly effective therapies. I can't go over everything in multiple sclerosis and all the treatment options, but I think it's important to explain how we can use highly effective therapies, because you should at least know that there are drugs that can be used and can be used safely in people who have active MS. So natalizumab, Tysabri, is a monoclonal antibody against VLA4. So it doesn't suppress the immune system, but it blocks lymphocyte entry into the central nervous system, and it's quite effective at that. It's well tolerated, once a month infusion. It's for relapsing MS, not progressive MS, and works very well in people with active MS, just as an illustration, where the more active they are, the better they may be able to respond, or the higher likelihood of yield. A patient with 1 relapse in the prior year has if they've been naive to drug, compared to placebo, they have a 68% reduction in relapse rate and a 42% reduction in the risk of disability progression, and are more likely to have no evidence of disease activity by taking this medicine. And those benefits are even greater if someone has had 2 relapses in the prior 12 months. An 81% reduction in relapse rate, a 64% reduction in the risk of disability progression, and are 16 times more likely to have no evidence of disease activity. The converse then would be, if someone doesn't take this highly effective drug, the people who were on placebo, they were very likely to continue to have active disease. This drug has a very clean side effect profile, with one circumscribed side effect that we can predict, and that's PML, which we haven't seen a lot of since the AIDS era. PML is a terrifying disease. A third of people can die if it's caught late. If it's caught early, about 1 in 30 people die. The PML risk is predictable. About 40% of the population of adults does not carry this virus. And you can test by running their JC antibody status. So if they're not a carrier of the JC virus, the risk is 1 in 10,000, and they can continue this medicine indefinitely. So for that 40% of the population, you can think, well, this is a great medicine. Why aren't they trying it? And that's one of the questions I'll ask. Why not give a highly effective therapy since the cost for this person is low? For other people, if you carry the JC antibody, the risk varies depending on how long you're on the medicine, as well as for if you've had previous exposure to immune suppressants. So I'll talk about people, we don't usually have people who've been exposed to immune suppressants. So if you have a low titer of the JC antibody, the risk is less than 1 in 10,000 for the first 24 months. You can think of it as a stepping stone for a chunk of time. I may not bring it all the way up to 24 months, but I may think, how about a year, 18 months of a highly effective therapy, and then transition to something that's similarly effective, or move laterally from there. Beyond 24 months, if you have a low titer of the antibody, the risk is about 1 in 800. For people who carry a high titer of the antibody, risk is about 1 in 1,000 up to 2 years, and then it rises to 1 in 100. I will tell you, I don't usually use this medicine in people who are high titer, and people who have a low titer, I will use for a short period of time for a specific purpose. But that's me. The B-cell therapies as a group, ocrelizumab, ofatumumab, rituximab, are all anti-CD20. If you're not familiar with this immune therapy, they do not suppress the plasma cells. They suppress the mid-lineage B cells, some of the antigen-presenting cells. The rituximab has been used in many MS centers for 15 years, but it's never on label. They never took it to a phase 3 trial. In fact, the company that made rituximab put it to the side, and because it was already well into its patent life, and they made a new version, ocrelizumab, which is humanized, but essentially is the same thing as rituximab. Ofatumumab is just a fully human antibody that's a monthly self-injectable. All three are highly effective for MS. The main concerns that you should think about are they're contraindicated if you have hepatitis B, and they will reduce humoral responses to vaccines. That is, if you're vaccinated while on these medicines at full strength, you're less likely to have a good antibody response to the vaccine. Whereas if you're vaccinated prior to starting the drug, you would expect to have a good antibody response. Over time, about a third of patients have a reduction in total immune globulins, but this is often asymptomatic. We will have patients who start having more respiratory infections. They're usually benign, or they're things that are treated with an outpatient antibiotic, and it's the distinct minority of our patients that have this. Opportunistic infections have been seen in the literature, but they're rare. The PML risk in lupus for Rituxan, where we have a lot of data, and lupus has itself a risk of PML, even in that large data set, the risk was about 1 in 25,000. So it's not a risk in the way that Tysabri is. Furthermore, and an important note in a time when I'll consider rituximab is that while it's off-label, we have extensive experience using it, and 11-year cohort data in rheumatoid arthritis showed no excess cancer risk. And when you're using immune therapies, it's nice to have one drug that you could have in your pocket and think, if this person has a history of melanoma or breast cancer, what can I do to explore treating without feeling like I might be responsible if they have a recurrence, or if the patient doesn't want to have that dissonance of, am I running a risk by trying to treat my MS? So to try to demystify the case in front of you, now that I've talked about the drugs, now we have to talk about patients. The first step is to ask, as Dr. Stark noted, is it MS? If you're not treating MS, if it's a mimic, or if there's something else going on, you're not going to get results. And then you try to be objective with the risk assessment, not just how they feel, but does the MRI show enhancing lesions? have, over the past 2 or 3 years, there have been new lesions that evolve or expansion of the old lesions. I will tell you, if you're seeing a lot of expanding lesions, there's something strange going on. You really should just be seeing new lesions. Most lesions will barely expand in MS. And then I'll look at both the number of relapses they've had as well as how well they recover. A person who's only had 1 relapse 2 years ago, but they didn't recover, they need urgent, complete care because they may not be able to, they may not remyelinate well, or they may have tapped out their reparative capacity, or their immune system may be more aggressive. And then I'll look at their level of disability, both what they describe as well as what I'm seeing, and I'll take both into account. I'll do a careful assessment of symptoms, and I'm going to talk a lot about symptoms today. I'll take in a careful assessment of other medical factors that could aggravate the disease. I'll look for evidence of progressive MS and take in a careful intake of the psychological factors. Both things like depression, but what they think of MS. Do they have a family member who had severe MS? And I'll take an intake of their behavior. Because really, to get a good result, you have to take all of this in. Both not just treating the MS, but looking at the whole picture, because what they know is not their MRI, they know their experience. If someone has simple bread and butter, relapsing remitting MS, here's the strategy. Your goal is just to keep their life on track. Know who they were before they got this diagnosis, and then try to make a plan that's congruent with what they've always wanted to be doing. The easiest part, most of the time, is stopping relapses and new lesions. I'll say that sort of should be, if not taken for granted, that should be assumed that in the first 18 months, you'll be able to pull it into control, meaning you don't have to start with an aggressive therapy, but if you tell the patient, here's where I'm headed, if we don't get the results with the first way of going about this, this is a technical problem, and we should be able to get you on track with a second treatment. So again, that's the easy part, stopping relapses and new lesions. But the important parts are to have them buy in. So a long discussion where you walk them through the evidence that they have MS, and that you address potential concerns so that you may already test for Lyme disease, even if you don't think it's Lyme, just so that you can say, I've looked for things like Lyme, because people will have they'll go through a whole process of navigating acceptance with a chronic disease. And it's helpful if you can show that you've thought about this and show them the lesions on the MRI. At the same time, while you're showing them the MRI, and I'll say, you see this spot on your MRI, that's not why you forgot your car keys. And it's important for them to hear statements like that. I'll tell them that accepting a diagnosis of MS is not the same as accepting disability. That's key. That when the old story of what happened to people with MS isn't the new story. We're not expecting them to have to accept disability when they buy into this. I'll look at both the risks as I'm seeing them objectively as a biology, and things like the relapses and MRI lesions and lesion load and atrophy. And then I'll take in their risk tolerance, and also on the other side, their disability tolerance. I think we have to recognize we have a treatable disease. Do no harm is owning both aspects of the process. Both, you're asking them to consider taking a medicine that could cause risks, but it's not fair to not, I don't want to scare them, but I have to be able to say no one wants to tolerate disability. It has a huge emotional and financial impact, and many times it can't be undone if it's been sustained disability. So when I'll take this whole assessment and try to make a plan that's congruent with what they want. I'll make opportunities, lead them through it like a coach, and make outcomes. And the goal is no evidence of disease activity and a good introduction. You want to make it easy, so they take a medicine, they're scared, but then they say, okay, this medicine didn't cause very many side effects and I'm getting a good report. And I want to be able to ask them, can you tell you have MS? And can you tell you're taking a medicine? That's really golden, especially if they have a great sense of wellness, because then it's generally self-sustaining. And if they feel well and you're still getting no evidence of disease activity, you would be able to detect if there was a gradual, slow process. Since the MRI doesn't capture everything in MS, and relapses don't either, if someone starts out feeling well and they're still running, you'd be able to detect if your therapy you're giving them isn't adequate, as opposed to if they never get back to normal, and then they say, well, my leg weakness comes and goes. So that returning to normal, if possible, is a great starting point, and it allows you to see the disease more clearly. So that's actually, this simple thing I'm talking about actually demystifies the disease. Even though I don't see all of it, I can know someone consistently feels well, and in 2021, that's as good as I can do. But I won't continue to say, well, maybe I should be trying something else. So then I'm going to talk about both the treatments for secondary progressive and primary progressive MS, as well as the overall strategy. So siponimod, cladribine, and mitoxantrone are approved for slowing progression. Ocrelizumab and rituximab were not formally tested in secondary progressive MS, but are often used. So ocrelizumab was approved for primary progressive MS. There may be biological differences, but it seems to work for both types. I think there's a lot of overlap between these diseases. I'm pretty agnostic. I'll try things that are reasonable, work, and look empirically for, can I get results, and what was a reasonable play to make here. There are no head-to-head trials for these highly effective therapies. If you were to select people who have had several years of disability, so someone who's freshly disabled, that's not secondary progressive, but someone who's had several years of disability that hasn't gone away or is slowly moving, within that group, there are people who are more likely to respond or have a reduction in disease progression. Those would be people who've had relapses or evolving MRI lesions, and younger patients. Also, people who've not tried a highly effective therapy. So that someone who's had no MRI lesions and then tried Rituxan for 2 years or Ocrevus for 2 years, and I say, well, can I do better? I have to be pretty humble and say, you've already tried a highly effective therapy, and even before you started that, you didn't have classic inflammation. You're less likely to respond. So, and then for primary progressive MS, all of the therapeutic optimism that I talked about in the last 20 years, that's been for relapsing remitting MS. There've been a lot of failed trials for primary progressive MS, including stem cell transplants, Copaxone or glatiramer, fingolimod, interferons, rituximab, and then the new version of rituximab, ocrelizumab, was shown to be modestly effective. And here it is, reduce the risk of disability progression to 33% versus 39%. And that's a 12-week confirmed disability progression. It's just one of the ways we describe how sure are we that this is real disability progression. We also do a measure of walking speed. How fast can they walk 25 feet? And that with people on drug had a 39% decline versus people who are on off drug who had a 55% decline. This benefit persisted in an open label extension of 6.5 years, which is one of the things we want to know is, okay, it's a slim benefit. How meaningful is it? And that was that open label extension had 86% of the initial trial participants. A thing to note is with this wasn't classic primary progressive MS. This trial group was enriched with people who had more classic inflammatory activity. 20% had an active MRI, and they tended to be younger. So one of the reasons ocrelizumab may have succeeded where rituximab did not was the equivalent of jury selection. They did a good job, but this is what they're supposed to do is show, and I'll give it to them. They move the needle, and that's important because it starts to break down a construct that nothing can be done. So it's not a terrific drug, but it does show that we can help. An important note, and it's just a question mark, is that neoplasms were seen in 2.3% of the treatment group versus 0.8% on placebo. And in one of the other trials in relapsing remitting MS, there was also a slight increased risk of malignancies. When the data has been pooled together, it doesn't seem to be a strong trend. And when in extension trials, it hasn't been consistently shown, and it doesn't seem like it's a true risk over time. This risk was within the range, the 2.3% was within the range seen in MS cohorts on placebo when we look across a number of trials. So it may be just this was a healthy placebo group and they just got unlucky the way that statistics can work. I'll only mention this because I may not hurt a person who has a serious solid tissue organ cancer on a Ocrevus for now, even though I would say it probably doesn't have a cancer risk. So I've talked about the medicines and some of the strategies for these diseases. But when someone comes to me, we have to just demystify a whole case in front of us. And the questions I'm looking at when someone comes into me symptomatically are not, what are the drugs for secondary or primary progressive MS or relapsing remitting MS? It's, what is the best new baseline I can get this patient to? Is there objective evidence of treatable inflammation? Have they tried one or two highly effective therapies? Or do they have a primary progressive MS? Is that really why we're not getting results with these drugs, is they never had a relapse in the first place, and that they just have a difficult to treat type of MS. It's important as we're trying to demystify, if I can't see everything on the MRI and I can't read everything by relapses, you look with agency for treatable compounding factors. And I'll come to a whole slide about that. I'll ask myself, this person who's in front of me, they're not doing well. Is it sustainable in their whole life and what they have in front of them to do nothing and say, this is as much as I can do? Because that's part of the sort of the risk analysis, is what happens if we don't act because we have uncertainty. And that wouldn't necessarily be treating the MS. I might say you need orthopedic surgery, or you need a sleep study, or you need, but we have to say, or you need to treat the depression and your MS, for example. So, but I have to say, is it sustainable to do nothing and just say, we'll continue the drugs? And then can I safely try a more effective therapy? So then I'll build the evidence by all the tests that you might need: sleep study, labs, MRI, urology consult. So this is what I'm thinking about with demystifying the ongoing symptoms, and then I'll treat those ongoing symptoms. I'll treat the MS with a highly effective therapy if I think it's appropriate. And then I'll look at the whole set of problems. So people often come in with a mixture of these problems up above: neuropathic pain, neurogenic bladder, urine infections causing pseudo-exacerbations. They're depressed, or they've lost their ego strength. They don't have even a good narrative. And I'll look at these problems as opportunities. I'll think about the synergies of problems, say urine infections keeping someone from moving as well, or a neurogenic bladder keeping someone from sleeping. So I'll say, can I get two birds with one stone? I'll also ask, are my treatment medicines making things worse? And I'll ask, how can I treat one problem without exacerbating others? My goal is, what problems have to be fixed, and can I change their narrative? And then if I come around to having targeted their symptoms and it doesn't help, should I go back and revisit the MS and ask, should I try another treatment? So a few notes about when to refer to an MS center. People who are on a highly effective therapy and are just not responding and have classic inflammation should say, is that there must be a technical problem. we're very comfortable with addressing these patients. People who have MS and concurrent systemic immune disease, Sjogren's, rheumatoid arthritis, for example. People with relapsing MS who, for reasons that aren't explained, are just not thriving. They've just never done well since the beginning of their MS. It's worth saying, can we kick the tires, and is there another way to look at it? Women can be safely taken through conception, but people who have very active MS, they need to be handled with some consideration. And people who have complex symptom management. I know I'm running a little bit over, I'm sorry for starting, but these are the last couple slides. COVID, people should understand a little bit about this. MS does not pose any risk to the severity of COVID. Severe COVID is higher in people who are elderly and disabled. And some of our medicines may slightly increase the risk of severe COVID. I'll make an analogy to being 30 to 40 pounds overweight. It's not the same as having an organ transplant, which is a definite increased risk of severe COVID. So these therapies may increase the risk. The B-cell therapies, the Gilenya family therapies, the high potent immune suppressants, cladribine and alemtuzumab. And this is notable because you may not think about it, but corticosteroids are definitely have an increased risk of severe COVID. So I would isolate someone who needs steroids for an exacerbation. Vaccines are okay for our patients. At least the currently available ones, Pfizer, Moderna, Johnson & Johnson, have no contraindications for people with MS. There were several cases of myelitis in AstraZeneca trials, at least two, one with MS, one with the transverse myelitis, and I'm told there are another 2 cases that have come out. It's not available yet, but I would probably, I won't poison the well on this, but I would say I'd bias towards the ones that are currently available. It's notable that people who are going to be starting these high potency therapies of ocrelizumab, alemtuzumab, and cladribine, these drugs will reduce the efficacy of the vaccine, so consider vaccinating prior to starting. Or dose the vaccines at least 12 weeks and probably as late as possible from the last infusion. You probably, if it's ocrelizumab, you probably need to see the B cells start to rise to increase the probability of getting an antibody response. Right now, we don't know how much the efficacy will be reduced, but probably enough that they could still get infected, but they probably would have, at least with the B cell therapies, they'd have a T cell response and should have some protection against a severe infection. So if I can sum up, this is what it looks like when we're talking about how to take in a patient with MS. This was a patient who came into me about a month ago. Her name isn't Susan. She's 50. She comes in newly diagnosed with MS. And all she knew was that for the past 4 years, she's had progressive fatigue and cognitive impairment. She stopped working 4 years ago because of cognitive difficulties and the emotional distress it was causing her. And she wasn't able to return to work. Her life became more and more difficult, and she developed secondary issues. A lot of stress, a divorce, wasn't sleeping well, developed headaches, was evaluated and told she had Lyme disease. And then an MRI for the headaches was consistent with classic relapsing remitting MS, including active lesions. And then the other data coming in was the serum Lyme test is positive, but only with IGNX, not with Quest. And when we did a lumbar puncture, it was consistent with MS. Classic MS, immune response in the spinal fluid, not in the serum, and no antibodies to Lyme in the spinal fluid. So you'd say, well, there's an immune response in the spinal fluid, it's not to Lyme. So you have to take someone like this who is a mess, and it's not a clear read. It's not like they have a relapse. They just had headaches, but they're in trouble, and you have to educate the person to begin with. So step one, this is MS, and I have to walk through the data carefully. I have to bring in their ID doctor and have them agree with it, that it's not Lyme disease. And then I have to look at not just the MS, but the insomnia, she's perimenopausal, and the stress may be adding layers to it. My risk assessment is she's got active MS. Clearly, she's at risk for more active disease if we don't treat it. And she's already partly disabled. In fact, it's not stable. It's not safe to keep her where she is, even though I can't prove I have agency or where I have agency. But the opportunities are she's got untreated active MS and she still has a good neurological exam. She just feels terrible and she's got cognitive difficulties. So my treatment approach is just so that they don't keep wondering about the Lyme disease, I'll say, fine, continue the doxycycline for the full course. And then I have to give her a highly effective therapy, but she hasn't vaccinated against COVID. So I actually gave her natalizumab. Again, coming back to, I can use this drug safely as a stepping stone with a plan to move laterally later. So I want a clean drug that won't cause problems like depression or side effects and is likely to give highly effective therapy. And then I have to address the other issues concurrently. I can't reduce the ambiguity other than treating everything. The MS with the natalizumab, the insomnia, and the treating the depression, and encouraging her gynecologist to give her some hormone replacement therapy because that's also affecting her. And my next step in the plan is to vaccinate and in a year consider B-cell suppression. And I'll have to come back and revisit it, but this is the way that we will synthesize and try to reduce ambiguity based on some simple principles as well as some objective evidence. This is what it looks like. So with that, thank you, and welcome any questions.
Thank you, Dr. Stark and Dr. Williams. If we could please open the floor for a Q&A. You can either drop your questions in the Q&A or in the chat box below. We have 2 questions already from Robert Klein. He asked, what do you tell patients on rituximab about COVID vaccination?
I'm sorry, my volume. Oh, so what do you do once you stop natalizumab? So with natalizumab, people can have a rebound if they're not on any, if they don't go to anything, if they go to an ineffective therapy. Natalizumab will wear off over about 12 weeks. So I will, it depends on what the reasons were for stopping it. It's usually that they're JC antibody positive. We have transitioned a lot of people from natalizumab to B-cell therapy over the last 10 years. People do very well with it. In fact, a comparator, it wasn't a formal trial, but a comparison cohort described people coming off of Tysabri and going to Gilenya versus rituximab. People with rituximab did better. We've taken a lot of people through this transition. I'll see it as how good was the baseline with Tysabri, and I want to keep them at that baseline and move them to something else. There are other people where I might de-escalate to something less effective, but I wouldn't put them on nothing, just in case they're going to have a rebound after that 12-week point.
Thank you. Leah Weinsfeld would like to know, can you please comment on stem cell trials in secondary progressive MS?
So we have
yes.
had a phase 1 trial that was completed a couple of years ago in secondary and primary progressive MS patients, in which we gave them their autologous stem cells, so they're taken from the patient's own bone marrow as a and then they're put down a neuroprogenitor precursor lineage, and then they're re-injected intrathecally, meaning through a spinal tap. And phase 1 trial was 3 treatments over 9 months. It was phase 1, so it wasn't blinded, it was open label, everyone was getting treated. And we saw some improvement in the less disabled patients. And the biggest improvement that we saw was in lower extremity strength and bladder function. So that is, and it was our primary endpoint of EDSS was met. So we have been doing a phase 2 trial for the last few years. In fact, just had a meeting about it 2 hours ago. And right now, 12 of our patients have finished the phase 2 trial. And that is a double-blind, placebo-controlled crossover design in which patients, again, get autologous mesenchymal stem cells administered intrathecally. But this is 6 treatments over a year, so more treatments. And then they are either in the placebo arm, which is a sham spinal tap, versus the treatment arm. And then after a year, year they switch. So everybody does get cells at some point during the trial. We felt like that was the most ethical way to sort of do this in the way that we had to scientifically. We have no efficacy data from it yet because only 12 people have finished. I can say the safety data has been in line with our phase 1, in which there's really been very, very few safety issues, mostly surrounding the LP itself and a headache. And so we should have some more data about phase 2, hopefully maybe an interim analysis at some point soon.
Thank you. Robert Klein would also like to know, what do you tell patients on rituximab about COVID vaccination?
It's a great question, and I've basically answered it almost every day for the past 3 months. I will tell them that it's probably going to prevent them from generating antibodies. I'll look at it this way. In the flu data, we know that when it's been tested, and it's hard to test, but we can show that the T cells generate a healthy, robust response. And people are going to be unnerved when they test their antibodies, the spike protein antibodies, and they don't have spike protein antibodies. And I'll tell them in advance, this is probably going to happen. My view is this is early and we don't know. The risk of COVID is not the same as HIV or Ebola. And I'd rather you have some protection now versus play a strategy guessing game about optimizing something that I'm not sure how to optimize. We've had one of the academic leaders said, wait 3 months after infusion. Other groups have said 6 months. I know that Rituxan is commonly used in Sweden, and their center was telling one of my patients, wait until the B cells are fully elevated, which might take a year. And so we're guessing, smart people are guessing, and you have to say, we're gonna laugh once we have the real data in. Why don't you give them some partial protection with an anticipation that you'll be able to shore it up with a booster at some point once we're smarter. And if you educate the T cells and they get infected, so you'll say, take the vaccine, still wear your mask, be safe, but you can hug your grandchildren. If you get infected, there is a monoclonal antibody therapy that will rescue the one part that may be deficient. So there's a strategy to this where you can say, be cautious, don't think you have 95% protection, but know that there's a backup plan that is highly effective at preventing hospitalization. That's what I say. It takes about that long every time.
We're also actively looking at this now in a research protocol and should have quite a bit of data in the next few weeks because, you know, we're waiting for the people that got vaccinated twice a few weeks after the second dose and they're on a previous Rituxan. So that's not a huge number right now, but we should know a lot more soon. So in the meantime, still use a mask and socially distance.
Thank you. Dr. Ronald Menzen would like to know, are the costs of these specialty medications causing patient non-compliance? Are PBM drug lists keeping up with the published literature for treatment regimens?
I'm sorry, you faded out.
Oh, I'm sorry. Let me try again. Are the costs of these specialty medications causing patient non-compliance? Are PBM drug lists keeping up with the published literature for treatment regimens?
So all of our MS drugs are very, very expensive. Drugs from Avonex from the 90s is almost $100,000 a year. I will say a lot of the companies are good about patient assistance programs. So Tysabri and Ocrevus have excellent patient assistance programs. If you're eligible, which Medicare patients are often not. But it is a huge problem in medicine in general, specifically in multiple sclerosis, where our drugs have outpaced inflation by hundreds of percents.
Thank you. Are there any other questions from our viewers?
I'll add on that note then, even patients who've not had insurance, the drug companies, they're making money hand over fist. The drugs are more expensive than similar biological drugs in rheumatoid arthritis. And even the old medicines have risen in price fourfold. So drugs that are now way outpaced by more effective therapies, they're all going up. the drug companies have free drug program. I've had people lose insurance. I've usually been able to obtain free medicine for people so that if it's ironically, the drugs that are making the most money are the ones that are easiest to get for free. For years, we couldn't get Rituxan for some patients, and Genentech consistently gave us Rituxan for some patients for several years. So this is something it can be done, and it's worth asking, and you're welcome to email me if you're having difficulties or ask around the drug companies, but there are ways to make it happen. And it's unaffordable for anyone.
Thank you. Okay, with no other questions, I just want to say thank you again for your time, Dr. Stark and Dr. Williams. The recording of this webinar will be available on our website, social media, and YouTube. And feel free to share it with those that you know. Thank you again for your time, and have a good night.
Bye-bye. Thank you.